Can you see the screen? Okay. So I'm going to try to make this brief, although our history goes way back in time. So it's going to be a little lengthy, but I'm going to do my best here to go through it. I will, the slide set is uploaded actually without the cartoons. I usually take those out, but is uploaded otherwise so that you can read that at your leisure because we will not get it all done today. So, okay. So we're going to go way back in time to Sri Lanka. Actually, one of the excellent psychiatrists up at North Coast is from Sri Lanka. I've talked to her a little bit about this in the past because obviously they learned some history that we might not. And then you jump to the first psychiatric hospital in Jerusalem. So again, we're going way back in time. All that jumped us into AD. And then the Bethlehem Royal Hospital, which most of you have heard of, you just probably don't know it. It is the genesis of the word Bedlam that we talk about from how bad state type, federal type hospitals were in the past before medications. So Bedlam, and I actually had the opportunity of visiting Bedlam, Bethlehem Royal, and giving a grand rounds there way back in 2006, I think it was. And they have all the archives of all the history there. Amazingly enough, they had and I'm not kidding about this, every medical record going back centuries at that hospital. So for me, that kind of started my journey of interest in this history. I ironically gave a talk there about, although a little bit different than this one, the history of American psychiatry, which of course started in England in a lot of ways. And so it's fascinating to me. That hospital's moved a bunch of times now in England, but it's still Bethlehem Royal is one of their main hospitals. Um, the other one that's important here for those of you interested in the history is lunatics first came out a long time ago, and eventually, 1700, we switched to patients. So in the scheme of American, or not American, but human history, not that long ago, we finally shifted to something better than lunatics, which of course is related to Luna the moon, that belief, which mostly is not proven in any science, that when the moon is full, that there are more people with mental illness. That really does not play out. Although I know a lot of clinicians who say, "Oh, yes, it does," even today, who believe it. So it's research says no. And then they began having public visits. Imagine this now. It's one thing to go to the zoo and look at the giraffes or what have you, but to go and pay a penny, which at the time was a fair amount of money, to stare and laugh at the patients. And you see 96,000 visits. Remember, the population was smaller back then by a long shot than the world population now. So that's a lot of people visiting Bethlehem Royal or Bedlam. And then if you're interested in forensic psychiatry, this is the hospital where Daniel McNaughton was treated. He is really the case we think about for even Ohio's law around not guilty by reason of insanity. So that case goes way back, and then forensic psychiatrists learned this in a lot of detail. But just to give you that quick piece of forensic history as well as we go, here he is, an actual photo from the time. As you know, they had a very different way of doing photography back then, but that's him, and he is the nidus of the laws that we have here in the United States as well. A little bit of pictures here of people visiting. Notice the people very well dressed, paying their penny to visit the people with mental illness, right? So I can't even imagine that as, gee, let's go out on Sunday and go to the hospital for that. This is what it looks like. This is actually still basically what it looked like when I visited. There's a nice, it's very nicely set. You walk through here and you walk through these two statues that give you a picture. These are the two statues which are now inside the building in the archives. And it basically there is melancholy and there's mania. And so they kind of distinguish those two parts of bipolar, but mania would include psychosis in here. So there's your melancholy. That, of course, is more likely the mania with the agony or the psychosis. So this is what people would walk through as they entered as a patient or as a visitor. All right, for time's sake, we're going to jump way fast forward to Benjamin Franklin. Who I had to look it up because I also in the history read he started the first insurance company. He's done so many things. In today's dollars, he would be worth $10 billion with all the things he did in his lifetime. I had to look it up because I was curious. And as you may know, George Washington actually was one of the wealthiest presidents in our history. It's just that nobody thought about that. I think back in the day, he was worth 500 million. So not as wealthy as our current president, but in the scheme of presidents, he was one of our wealthiest. So a lot of history here with Benjamin Franklin. You've probably heard of the Pennsylvania Hospital. This was really one of the beginnings of modern type psychiatric hospitals. And then in Williamsburg, they created the first public psychiatric hospital. That was the only one until 1820. So really fast forwarding here as we jump forward, a lot of stuff was going on in Europe. Again, we were a new country in this window, not even fully our own country when Benjamin Franklin created the one hospital, but we were a new country as we move into some of this history. And Italy was already doing a lot of work trying to come up with better ways of treating individuals who were in these asylums, the nicest word that was used back in the day. And of course, again, no medications, right? So when you think about what happened, well, people were kept in cages. If you've seen Hannibal Lecter with the thing on his head, that was a standard kind of treatment back then to keep people from biting other people, chaining them to the walls and the like. Horrible, really, but in the scheme of things, what else were they going to do back then? It's a little unclear what they could have done. This moral, which really meant morale back then, so just to be clear on how the word was used, this moral treatment was really initially used in the York Retreat in England, which stood the test of time for a lot of years. And that actually was followed in the United States by the Shepherd and Enoch Pratt Hospital in North Baltimore, which happens to be where I did my residency training. So I know a little bit more about that history, and it's still a Quaker board. So when they have meetings of the board, it's used as a Quaker model as opposed to a Robert's Rules of Order or a policy governance like our ADM board of trustees uses policy governance and so forth. So Quaker board, lots of discussion in the meetings, but a vote is silence. So when you pass a motion, if nobody speaks up, the motion passes. So a very different approach to the world. But the Quakers really, with a lot of money from Sam Shepard and Enoch Pratt, were able to pull this off. A working farm, patients would enjoy a day, if you will, of activity, which was productive. And that helped a lot of individuals as opposed to chaining them to the walls and so forth. And they improved their morale. I've got pictures from Shepard Pratt in the past where they also then came in, people got dressed up, the patients as well, for dinner, white linen tablecloths. It was like going to a fancy restaurant for your meals. Very different if you think about that, how we would all behave differently if we always were dressed up to the nines, as they say, as we met with each other in public settings and so forth. It really does set a different tone as opposed to, oh yeah, I've got my ripped jeans on and my ripped up shirt and all that sort of thing. So, and our society, of course, has moved way more towards casual as we've done these things. So in 1800, around that time and beyond, you can see here a lot of changes. Philip Pinnell, this is probably one of the most famous paintings. Here, I've actually got a version of this, obviously a reprint in my office at the ADM board. And it is his moral treatment of insanity. Again, not quite being used in the legal term back then, but wide circulation. And he actually went in and demanded that they free the patients from their shackles. Like, let's stop this kind of treatment. And again, it was already rubbing off in America. We were already doing this at Shepard Pratt and some other places. And then you move into the 19th century here with a lot of institutions. Right now, this is when we started to grow the institutions across the country. I'm going to do a little focus here on Ohio. So we did create one in 1821. This commercial hospital and lunatic asylum for the state of Ohio in Cincinnati. That you can see that, like now, it took years to build, but it did open in January of 1824. And the concept here was to give people this better setting for treatment, albeit, again, long before medications. Did change its name to Longview in 1860, and then the current state hospital there is not the same location, very different setup. But Dr. Daniel Drake was one of the big names here in the United States and did some work here in Ohio. And so they actually created the first, quote, insane department, which we would then eventually call Ohio Department of Mental Health, now Ohio Department of Mental Health and Addiction Services, and very soon, in this, because of the new budget that passed, the Department of Behavioral Health. So that is also bringing you to current times. So here we are. They did the lunatic asylum of Ohio, and this is huge. Obviously, you can see how big this is. Central Ohio. So this is now Twin Valley, Columbus area, and it was. Notice it was. You can see how dollars change. $61,000, right? The North Coast new hospital that was built. I guess 10 years ago or so now was like 65 million to build the current North Coast. So big difference. And yet this actually was, I believe, the second largest public building in the country at the time, second only to the Pentagon. So it was a very, very large institution in terms of that. And then in 1851, Ohio codified this concept that institutions for the benefit of the insane, blind, deaf, and dumb, again, using old terms, shall always be fostered and supported by the state. This is actually, as a quick aside, my argument for why Ohio needs to do something better than the current gridlock that we have in the state hospitals. They're required to still, this is still the language in our Ohio state constitution, that they need to do this, and they're not doing it. So we really need to have some changes there for all of us, and for the people that we care about and the people that we treat. So very, very important. You'll see here that others were built. Obviously, Cleveland. Here's Cleveland State as a hospital, and that was huge. Eventually, North Coast Cleveland campus, and eventually we closed it. Actually, while I was there, and moved all the people to Northfield, the current location of all North Coast patients. Had become a money pit over time. A very, very old structure. This is not the one. It was a different one in downtown Cleveland that had been built. Okay, here we go. Let's jump to a name you probably have heard, Dorothea Dix. So in the 1840s through 1870s, she was hugely instrumental in getting these organizations, these institutions built all over the country. She happened to be, I think, a distant cousin, but still a cousin of somebody high up in government, and she ended up, because of that, having some clout with the government and even the president of the United States, and was given permission, and she traveled around the country. Now, remember, not by car, right? So imagine the amount of time it would take to travel the whole country. Traveled the country. And I remember Dr. Fred Fries had read some history and told me probably bipolar disorder. She probably was traveling with at least hypomania all over the country, convincing, apparently very convincing person, convincing the leaders of all the states to build these institutions. So that's really where we got most of our state psychiatric hospitals across the country, many of which are still there today. Obviously, we've closed a lot, even in Ohio, but that was huge for Dorothea Dix. We've got the Williamsburg Asylum, and that was huge. Also another one that really looked at treatment from this moral or morale version, looking at one from France, in Belgium area as well. The two of those, the France and Belgium, which of course were under the same rule at the time. And then one did this transition. So here we go finally. Well, what do you do if they don't need to stay in the hospital? Right? At the time, people lived there, basically, once they were in these hospitals. They started looking, well, maybe people can actually get better enough to leave the hospital. And so they created like a parole type system, and they can leave the hospital. And this is very similar to what we do now in Ohio with our forensic patients that have been found not guilty of reason of insanity or incompetent to stand trial, but under criminal court jurisdiction, ISTU CJ. And so it's like conditional release, and they are heavily monitored, as they are today. And it's, at least today, I don't know the old data, today's data is the recidivism is extremely low. Conditional release is a very, very good program statewide, and as well as in Summit County, Portage County, where NEOMED is, and so forth. So very, very interesting. They also created, in effect, residential and group homes. So look at the concept here, right? We're going back a long time before. This is 100 years before we had medications. So they were already thinking well about this. Now, here's Shepard and Enoch Pratt. Obviously, I'm a little partial to them since I trained there, actually on the same land where it was built, and in fact, in the same buildings. They've now renovated and designed a whole new inpatient building. But at the time, I was in those same old, really beautiful, actually, buildings, although very long buildings. So running from one call to another on call was a lot of exercise, but it was fine. So they did this courteous treatment model. Again, strong Quaker influence. You see that Dorothea Dix also went there, and so that's also important in the history. Um, Took until 1891 to actually open. Money was an issue, right? They had money originally from Enoch Pratt. If you've ever been in the Maryland area, Enoch Pratt also endowed a lot of the library system there and so forth. So a lot of money, but not quite enough to finish what became a very large psychiatric hospital. And Moses Shepard, having visited, gave more money ultimately, and that allowed this to continue to be built. So very, very important. They actually had this full renovation, as I said, in 2005, which was a number of years after I moved here to Ohio. Thomas Kirkbride, very important in inpatient settings. Still to this day, most inpatient psychiatric hospitals use what they call the Kirkbride ward-based model. It is, and I'm going to show you a contrast to that in a minute because there were some changes in recent times for some hospitals, but that was the model that basically you had an eating area, some treatment room type areas, and then everybody was in their rooms on the units. So it was all very much a ward based, and most patients, especially before medications, never left the ward at all, except in these morale boosting environments where you could go outside, maybe even work the farm and so forth, which was clearly better than the ones where you're locked in entirely for maybe your whole life. So lots of, I'm gonna jump fast here to cover these. So here's some old pictures. This is the original Toledo State Hospital. I started my career in Ohio at this hospital, albeit these buildings were gone. But so this goes way back in time to Toledo State Hospital. Eventually, that land, most of it was sold to the local and sorry, state government there, and there is University of Toledo Health Science Campus. So the in medical school, nursing school, those parts of the what eventually became part of University of Toledo are all on the land that used to be the state hospital. State hospital is rather small. I think now 114 beds all in one building. So it just gives you a nice glimpse here of some of the history. You can see what it was. It was the city, right? The city, 3,000 or so patients here. As I said, now they're down to 114 patients, so quite a difference when medications came along. Probably too small, right? We've gone too far with the pendulum. But this gives you a sense of how big this area was. It really was the city of Toledo, and eventually a lot of this land was ceded to the state to create eventually the University of Toledo and mostly what is now the Health Science Campus. Much nicer in color here. You get a sense of the cottages that lined the areas. This was similar. Northfield actually used to look a lot with a lot of cottages as well on how they housed individuals. Much nicer setting, I would imagine, than a Kirkbride model. Everybody should recognize him because you can't give a talk on history without putting Sigmund Freud on a slide. So Sigmund Freud really did rule the day with some highlight. He was, by the way, a neurologist originally, also had a problem with cocaine use. But with all that, he wrote a lot of interesting theories, some of which still hold true today. Id, ego, superego concepts. Obviously, these are concepts. Dreams, a lot of interpretation of dreams, one of his books. So a lot of information came from him. And if nothing else, it got us all thinking in the field of mental health differently about this. So we're jumping to the 1900s. So asylum, again, had a negative meaning, right? And in fact, they did a lot of horrible things back then. Right? They were involuntarily sterilizing people with mental illness. So not a thing that anybody wants to see done in today's world. And I want to just caution us because probably, 200 years from now, people are going to look back at how we treated some individuals with mental illness and think, wow, why were they doing that? Because the science just keeps getting better And imagine, if you will, that maybe psilocybin and the like will turn out to treat most mental illness. And then why we've been giving all these people high dose antipsychotics and all these antidepressants that cause side effects, right? So you just to put that in perspective, because it's easy to look at what I'm about to tell you and say, "Oh my God, what were we doing?" Right? My premise is our brains are no more intelligent today than they were probably 2,000 years ago. I don't think we've evolved that much, but as we've learned more, we can think about things differently, which is why I mentioned Freud. And then from that spawn new theories, more science and testing, and then of course better treatment. So that's true for all of medicine, not just psychiatry. Clifford Beers, this was a very famous book. Actually for a lot of years, a mind that found itself. And he was somebody who was in hospitals, did much better eventually, more of a depression type illness. And he actually started what became known as the mental hygiene movement, the hygiene being used a very different way. Actually, I think they've now recently changed, but in Maryland, where I grew up, their department was the Department of Mental Health and Hygiene for a long, long, long time. So they kept that old term in there around mental hygiene, which was really a mental health wellness kind of a movement. And they talked about, again, more and more this idea, which had started in the 1850s, outpatient clinics, aftercare, some social work services to connect people to how to navigate the world if you've now been locked in an institution, which rarely back then it was 5 days like today. It was going to be 5 years or more on the average. So think about it in a very different way. You were really cut off from most aspects of productive life unless they provided that in the institutions. So our up through the 1940s is where you hear about the snake pit type concepts. We were giving people malaria on purpose, trying to treat psychotic illnesses and the worst illnesses, insulin shock therapy, putting people into comas, hoping it would be a treatment. ECT, which actually is the only one that stood the test of time, ECT is phenomenal. It is probably still the single best treatment for depression. Maybe psilocybin will beat it because some of the studies are saying that it very well may. But ECT actually for serious episodes of major depression, the patients I've seen that have the worst are actually with bipolar type 1 who go in their depressive mode. They're very, very low on their moods with all the neurovegetative signs. And ECT is actually very good, but it's not done the way One Flew Over the Cuckoo's Nest demonstrated it, which is why it has a negative connotation even now. Even our current medical students seem to have managed to see that movie because I asked them, they're, "Oh yeah, we saw that." So, well, it's not like that. But they don't want to believe it because, Jack Nicholson did a great job portraying the old way. Lobotomy. Lobotomy for a period of time was the other treatment. It would, in fact, of course, cause people to be more docile because of what they were doing with the brain. So it had in effect, a positive effect. But of course, it also damaged their brain, and they weren't going to function very well in other aspects. So really not a good thing. But again, at the time, they were trying to figure out how do we not chain people to the wall? How do we not put them in cages? And on balance, I'll leave it to you to decide which is better. Finally, in 1934, the country created the American Board of Psychiatry and Neurology, the board that I'm board certified by, and I imagine Dr. Torm and others are here. So the American Board of Internal Medicine is the model for lots of specialties. ABPN is the one for psychiatry and neurology. Again, merging because it's all the brain. And as I said, Freud was a neurologist at the time as well. And so the teaching moved into psychiatric hospitals that are connected to medical schools, much like NEOMED, right? Being connected to Summa Hospital and Cleveland Clinic, and now UH, they've got a big model with a big contract with them. And so the concept has been there starting from 1934, not that long ago in the terms of human existence, to finally move us into a scientific approach. Again, predates medications in 1934. We haven't quite gotten there yet. We're getting close. So you can see here in 1940, there were over 400,000 patients. I think the peak was about 1955, about 550,000 patients in state and federal public hospitals. And then we'll talk briefly in a minute here about how that changed. The Snake Pit was a famous book published in 1946. The movie is still available. You can find the movie out there. Might even be on YouTube at this point for free. But in 1948, and it really was like Bedlam. It was like, let's show you how horrible these are. Again, predates medications. We finally had more funding coming out in 1946 through the federal government, and then the National Institute of Mental Health was established in 1946. And that, of course, has been huge to get more funds to create, to help general practitioners at the time, as they were called, primary care doctors now, to go back to residency, become psychiatrists. We had learned enough, and 1960s does include medications at that point, so that makes a big difference. You can see here, again, I'm going fast for time's sake, DSM-1, the Diagnostic and Statistical Manual. You're all aware that, and I'll show it again, but in 2013, we had the 5th edition come out, using the number 5 as opposed to a Roman numeral at that point. But that started our codifying. What do we know about signs and symptoms of various mental illnesses, and can we put them together in a way that we can both use it to treat, use it to communicate between various types of clinicians, and also, of course, do research to figure out what do we do to target these particular entities that were, in effect, man-made, but over time they've been based on science and much more likely to follow the actual biology of what's going on in our brains. Here's Athens, Ohio University, as some of you know, and some of you may have gone there for all I know. Ohio University. This, again, Athens, huge, huge facility with their own power plants, et cetera, et cetera. Now their hospital, I believe, is 88 beds out in Athens. So it's still actually in Athens near Ohio University. But just to give you a sense, again, a picture of where were we at, look how beautiful this is. Look at the patients. They're dressed up, jackets and ties, and the staff, same nice dress. I mean, what a different environment. Granted, there were some other people in other parts of the building probably chained to the wall. But the other patients, you could at least see the morale boosting of this kind of environment. Our hospitals don't look like this now. They don't look this nice at all, in fact. Just another view from the water there. Okay, let's jump to drugs real fast. Lots of drugs were tried prior to 1950s. Very few of them worked for much. Obviously, amphetamine has stood the test of time. Thyroxine did help some because, as you know, individuals that have hypothyroid disorder, we can give them all the antidepressants in the world. It may not solve their depression. They need to have they definitely need the thyroid hormones, but they also often need that and then antidepressants. So very important. Others have been used. Mostly, unfortunately, negatives have come out of the barbiturates and opium, other than maybe stopping seizures or something in barbiturates. So maybe withdrawal from alcohol use disorder, things of that nature. But it was a start. We had all these physical treatments, as I've mentioned already, different types of brain surgeries. Instead of lobotomy, a leucotomy, cutting some of the white matter tracts in the brain, things of that nature. And then finally, as medications came out in the 1950s, we have day treatment and halfway houses. So this is the beginning that we start to see that people can actually live in other settings other than these locked Kirkbride ward models. And we end up with 1961, 1963, the Joint Commission on Mental Illness and Mental Health. So that looked at the national scope of what was going on in this whole country. And that led to President Kennedy and the Deinstitutionalization Act of 1963. More and more is being learned from science. We get the DSM-2 in here. Here's Kennedy with his components. And I'll have to share this later just for time's sake. Or if there's no questions at the end, we'll come back to this. Interesting to watch Kennedy talk about this in 1962, but I'll come back to that for time's sake. So similar to doing this commission here, fast forward, as more was learned, and President Carter, when he was in there, he and his wife Rosalind really picked up the mantle of mental illness. In fact, I had the opportunity, being where I was in residency, to see her at a big embassy event that I was invited to. Shepard Pratt had a small contingent, and I went. And so I didn't know she was going to be there. And suddenly there she is at the podium in this tiny room. And I'm like, oh, I did not get to talk to her. But she did speak about it even then, about mental illness. That would have probably been 1996, I think, when I saw her, 6 or 7, when I saw her. So they went through all of this again and said, look, we need to do more. We need to do better. and they laid out a plan for this country on what to do. Again, not that long ago. And in fact, some of us were actually alive back in 1977. Maybe not all of you, but there you go. Here became the problem, right? So now we had a lot more to talk about, and of course, that creates some politics. And as you just unfortunately probably saw, the recent couple of executive orders that came out of the current president's office that have all of my listservs abuzz and my ADM board this morning at our staff meeting abuzz. But we'll go back to that, and we'll do that another day. So 1979, NAMI finally comes along. So this was founded by the NAMI mommies, literally what they called themselves, and it changed their name from National Alliance for the Mentally Ill to National Alliance on Mental Illness to be more inclusive. And the NAMI mommies are still that group, which has grown tremendously. Ohio has one of the best chapters in the country, maybe the best, according to the National NAMI. Very strong lobby, excellent advocacy to get positive changes, including in Ohio's budget under Governor DeWine, who's been very open to listening to the input from NAMI and others. Probably, at least in my time in Ohio, the best governor we've had as far as helping out with financial and good policies around mental illness. DSM-3 comes along in 1980, 1987. There's a 3R, which probably should have been the 4. 3R was actually a pretty big revision to the DSM-3 as opposed to the DSM-4 in 1994. The text revision was literally just a text revision. So this really was a text revision, but the 3R really should have probably been the 4. And you'll see here at the same time Prozac, right? So we finally moved from the older if you will, atypical antidepressants, I'll call it, just to coin a phrase, to the newer SSRIs and eventually SNRIs and all that. And then clozapine was the first atypical in the United States. It actually was from the 1960s in Europe. We struggled with that over here because of the probably now misguided belief about causing your white blood cells to vanish and causing infection and death. It turns out it's probably extremely rare for that to actually happen. 1990s, decade of the brain, a lot of money was done. We're still benefiting from research that was funded in the 1990s because some of these studies do take decades to get the full effect of. So that's been a good positive for us. I'm moving toward the end here real fast. Managed care, of course, came along. Yes, there were negatives to managed care. Managed care, my quick funny anecdote was I was in my 3rd year of residency. I'm on the high turnover inpatient unit, which back then we actually had one, up to 5 days length of stay. And I still remember my attending psychiatrist, an excellent guy from Peru, Dr. Carlos Escarte. We actually became very good friends. And he happened to have a bald head. And so we would get this chart, and we had the treatment team, and the patient would come in, and he would look at the chart, and he would read it over. I could see if the chart had a red dot on it, I could see his temporal arteries throbbing because, again, he had a bald head. And he would say, and Dr. Smith's going to take care of you. And the reason was that red dot meant that this was a person who had managed Medicaid, because Maryland adopted managed Medicaid decades before Ohio finally did. And so he would be, and that meant a person probably had a serious personality disorder along with whatever else they came to the hospital for. And if we kept her or him longer than 3 days, Shepherd Pratt was going to lose money. And so that's why his artery was throbbing. He'd hand me the chart and I'd work with a patient. That does not mean they always get out in 3 days. Just to be clear, I didn't have a magic wand any more than I do now. A lot of things came out of managed care that were positive. Quality assurance. The concept of a plan, do, study, act cycle, the concept of looking at outcomes and trying to improve what we do to get better outcomes really wasn't around when I was in medical school. And really wasn't a big deal when I was in residency, albeit Maryland had then adopted managed Medicaid while I was actually during my time in residency, it happened. But it has helped us in a lot of ways in all medicine and all types of behavioral health care. So I don't want to completely trash it because there are positives. Best practices came out of this, and evidence-based practice. Oh, wow, if we do the outcomes right and we do the studies, we can find out what actually works. So we can understand why United Healthcare wants to fund cognitive behavioral therapy, but not scream therapy. But prior to managed care, prior to quality assurance, you could not officially say that scream therapy was not as effective as CBT. Right. So that's the power of some of our history here. The recovery model then became a big thing. And I took a lot of slides out on that because there's a lot to it. But basically, it started to move us away from completely paternalistic, which was the phrase, could have been maternalistic, but paternalistic, where they came in and the doctor says, here's what you're going to do. And the patient says, thank you. Now, did they go do it? No, probably not any more than they do it now. But without motivational interviewing, all the good things that Dr. Spieth and others have taught us. But the concept was, I tell you what to do as a doctor, you go do it. And in fact, older patients that I've seen today still want that. They are not really interested in Googling it and reading about it and having a long conversation about it. They want to know what I want them to do. So some of that has stuck for people. Treatment malls was another big one that was a change. Here's my one managed care slide. Uh, Unfortunately, this is how it has felt over sometimes, probably sometimes currently, for some of your patients with prior authorizations and all those things. Recovery model. I did one, kept one slide for it. This came from the moral treatment concepts that I told you about. So it kind of brings us full circle here. And we had a lot of good people. Bill Anthony, Lieberman, Wing, Lamb, a lot of individuals. And then it was kind of codified by Dr. Bachrach. And they put out this concept of let's focus on some patient strengths, right? Wow, what a concept. And let's help them use those strengths in a recovery model. Again, this really meant both mental illness and substance use. So again, it also was a movement towards combining these two. This is not what's meant by recovery. I couldn't help but have one forensic joke. So this is not what they meant with recovery. Okay. Kirkbride I mentioned, so I'm not going to go through that for time's sake. Treatment mall I do want to mention. Treatment mall, we actually did a version of this in Toledo, kind of a makeshift model when I was there because I learned about it. And then Heartland, Behavioral Healthcare, actually when they built their new building, actually has a treatment mall layout. We were very much makeshift on our top floor in Toledo, which is a small hospital. Heartland has a much better model. The concept here is, it's in simple, you live and eat on your units, but you go to work, that is, you go to your treatment programming, your individual and your group therapy, and other things off the unit. Right? A much better model to what we really want people to learn to do. I'm a big fan of this. I think at its peak, it was maybe 30 hospitals across the country did this, and I don't think it held sway long, unfortunately, because of cost. More staff was required, et cetera. So I don't think it's gone anywhere. This is Heartland to give you a sense of this model. Where you can see the number of rooms here on the side. So you go to this mall, as it were. And it was called a mall because you might have a barber shop, you might have an ATM machine, you would use a token economy, and then patients could use what they gained in the token economy, usually some kind of coins or something, and they could trade those in for goods and positive services on the treatment mall. Here's a big list of the kind of things that were there, as well as staff offices. They might have their outpatient appointment, in quotes, because they're inpatients, on the mall. Oh, go see your doctor, your nurse, your social worker on the mall in between your groups and so forth. So I thought that was great. Okay, time's sake, I'll jump real fast. 1999, stigma. Finally, a U.S. Surgeon General felt he was comfortable enough, and it's a team, but Dr. Satcher said, you know what, we need a federal report on mental illness. Shocker, 1999. Talk about stigma until it got to this point. We ultimately have great recommendations from this Surgeon General. It's free, by the way. It was our tax dollars. You can go see it on the web. Again, you got to meet people where they're at. They may have different terms for the same thing. So I thought this was a pretty good depiction of that. In the new millennium, we redo again the Carter Commission and the original 1960s commission called the President's New Freedom Commission. It was done here 2005, 2006 by our own Dr. Mike Hogan. He was actually tapped by President George Bush Jr. to run that for the whole country. And he was my boss at the time, so I got to hear a little bit of the inside baseball there. But phenomenal thing. Sadly, it was very similar to the 1977 report because we had not done a lot to improve in all those years. Okay. We got rid of seclusion and restraint in many ways. In most of our hospitals, including the state hospitals, we really dropped that down, which had a positive effect on the patients because we're not re-traumatizing them. Turns out it has a very positive effect on the environment as well as, or the milieu, if you prefer, and the staff. Because guess what? Most staff injuries occur during exclusion and restraint episode. You're not doing that anymore, and you're using your words and your mannerisms and your nonverbals. You decrease all that. So that's a big one. SAMI. We finally, in some places people say MISA. I know Hawaii uses MISA, but SAMI mostly is what we say here in Ohio. And the idea here is treat them together. That was a novel concept only a few decades ago, mainly because you can't always tell who's got a problem like this. This is pretty blatant, not so clear in our treatment. Here's the new Freedom Commission. Again, you'll get the slide set, so I want to stop here quickly and have some time. Finally, Mental Health Act of 1988 was basically our 1963 Act, a little bit behind in Ohio on that. We shrunk our state hospitals from 17 to 9 and then 7, and now, of course, 6 state hospitals in the recent 15 years, I think. We do still have the 50 mental health boards. We do have 450 or more local agencies, that is across the state, statewide. We've got the centers of excellence based at medical schools. So in increasing this model, NEOMED has done this the best. The other one that does it extremely well is Case Western. So those two CCOEs have stood the test of time. Most of the other ones around the state have not. But they were a model from Dr. Hogan, Dr. Dale Svensson at the time that I was at the state hospital in a medical director role. They really were the designers of this concept, including what became the CJCCOE with Dr. Mark Munitz having a big hand in that when it started. Okay, here we are with that. Basically all forensic right now, and we will jump to any questions. I'll leave